Welcome back. Hopefully everybody has gotten their maybe second or third infusion of caffeine. I'm not a caffeine drinker, I try not to, but I have to admit I've had some today, getting up much earlier than usual. So thanks all of you for your participation. I wished we had a little more time built in, but please, I encourage you to use the chat to put in any comments or questions. We have someone monitoring that and they will put them up. So before I hop into the talk on roles and functions of patient or health navigators, I have a little polling question, or so actually a word cloud. So would you please use your word cloud and type in what titles are you either using or seeing being used in your area to refer to what we've been calling community health workers or patient navigators. So just kind of put into your word cloud. I think. Here we go. Good, good. I see some titles coming up. Okay, good. I see. Worker, community health advocate, coordinator, navigator. Navigator, worker, health, community coordinator, coach, see that one. Okay. Navigator, worker, community health. I see the word community, coordinator, advocate. Some of the same words are, as they get bigger, that means they're being used more. Coach is kind of little. Oh, social. All right, let's finish that and let's move on. As you can see, there's lots of different titles. We're going to talk about that. All right. The CHW are patient navigator roles and responsibilities, and we're specifically going to talk about today, I hope, is in relationship to the sickle cell medical team. Now, Shirley's going to be getting into this in much more detail. She's already done some talk about the medical care team, but then she's going to really get into some of the nitty-gritty because she's the woman who's been there, done that. She's been on this journey for several years now and really has that expert knowledge. Okay. I need my slides bigger. The chart here, I need my slides bigger so I can see them, since we started our project back in 2011, 2012, and I've been involved, a kind of little personal journey of mine was to see the number of different titles that people are using for what we saw as kind of the same kind of worker bee. So I've listed some there, and if you remember yesterday when toward the end of the day, we talked about what we have come up with, what we consider some categories. And I don't mean to say that this is a stepping stone or that this is better than the other, okay? We didn't know, we struggled over what to call it, but we called it categories. And in those categories, from the literature, we went back to the literature, and I'm talking several hundred different articles out there. We have some of the key ones are listed in your references, so if you really want to go look at the originals, go right ahead. But kind of arbitrarily, looking at those articles, placed these titles within the categories of which we are proposing. There is no right answer here, but that was what we did. So the last count, I had like 67 different titles. Does that not blow your mind? Now, I can remember being that I have nursing background, and of course Shirley she's a social worker, and so we both, our professions, and even you physicians, have had some struggles with making sure everybody had the right titles. And that gets important when you do licensure and all that. But to think that there's that many different titles to refer to what is somewhat of the same workforce. So I just did this chart. It's very busy. It's just to give you some sense of where all these people are and where we think they would fall in this category. So there's been a real evolution of these titles, and I mentioned this a little bit yesterday in regards to the history. Some of this movement really started with peer mentorship, and a couple of great examples of, I'm sure some of you have been aware of what was called Reach to Recovery years ago in regards to breast cancer. And women who had survived their breast cancer surgery actually would go into hospitals, because this program was developed, and work with patients in those early days post-op on how to deal with their mastectomy, how to deal with the exercises, and really became their peer mentor. And that program had been very, very successful over many years. It was sponsored by the American Cancer Society. Then when the HIV hit in the 80s, they also had a very successful models where those folks that had HIV or HIV positive worked with the community to not only do public education, but to work with those folks that were HIV positive. So we have some excellent examples of how peer mentorship can be very effective. I think in the sickle cell world, we still have that, and that many of you work within your community-based organizations. Some of you are working in institutions where you work with your community-based organization. And many of those folks are either family, parents, advocates, or they themselves have sickle cell disease. So there is a role for that peer mentorship piece of this pie that should not be forgotten. When you get into the community health worker literature, you will kind of not see that as much. But I think it's important, I do, and I've seen it in the literature. And I can tell you that one other very successful program going on in Virginia, as well as I know some other states, where peer programs are working with the substance abuse, alcohol population, and it's the recovering folks that work within their system to do very similar functions that the community health worker's doing. So community health worker became very prevalent use back in the 60s. And then you start seeing these titles called patient navigators, of which we purposely chose that title. And some of the reasoning for that, where I think Shirley's going to talk about it a little bit, but it was a conscious decision on our part in that we did not want to focus on the peer part because there was some issues with our institution and having access to patient information, and it just became one of those issues. It's like, you know what? Sometimes you've got to set your own battles that are reasonable. And patient navigator in our program, we worked with patients. So if you're a community-based health worker out, say, working in a federally qualified health center, not all of the people you're working with are necessarily patients. You may be out working in a community to do diabetes education. And most of the folks, the clients that are in your diabetes classes are not necessarily patients of that health center. So there is some differences there. But we purposely chose Patient Navigator, which has seemed to work very well. And then, as I mentioned yesterday, the title Health Navigator is really already very much specific, and that's been driven from the community college system, so that the title Health Navigator is actually the person who goes to a community college, gets an associate degree, and then practices as a health navigator or possibly a health educator. So as you can tell, there's a lot of different titles flying around, and it can really confuse people. The definition, I had this slide yesterday. It's the one that is used by the Public Health Association, and it's long. I'm not going to read it, but you could read it for yourselves. But it really has to do with the community health worker being that linkage person, the person who has their feet in the community, but they can link to that healthcare system. Just to mention, there was what's called the Coleman model. And Dr. Eric Coleman, back in the early 2000s, came out with a project that he called his Coleman model. And he talked about the 4 pillows. And what it was designed to actually save money of hospitals working with predominantly Medicaid patients, in that we found that Medicaid patients that had chronic diseases, diabetes, heart disease, would come into the hospital, have their major event taken care of. They'd go out, and within 30 days, they were back in the hospital. I bet you many of you are very aware of that scenario. And so he came up with what he called the 4 pillows, which was to work with patients regarding their medication management. He actually worked with electronic medical records so that there's good, clean communication between hospitals and patients and primary care providers, and that every patient that went out of the hospital should have a primary care provider in the community and not be using the hospital per se. And then also he had what he called the red flags. This was, we teach our patients, what are the reasons that you should come to the ER? If you've got a fever, you've got, chest pain, you've got symptoms of stroke, these are things you need to come to the ER. We want you to come in. So these were the kinds of things he was teaching. Like if you're a diabetic and you're checking your glucose and your fasting glucose is 210 this morning, well, you probably need to be calling in and doing something. But this program was very limited. It was the first 30 days following a discharge from the hospital. But because he wrote it up, got it published, and had a very well-prescribed program, and he, guess what, evaluated it very well, he was able to show very good outcomes and save dollars. So that's why he became kind of famous and was known around the country. And it was one of the first times somebody that really had something that clean to say, hey, if we deal with this, and guess what? He used community health workers. In our work, and I'll just show you this, in preparing for the grant we did back in 2011, 2012, we didn't have a whole lot to go on. Shirley was sharing how Dr. Smith and she and I kind of got together, and we were dealing with this whole idea of using community health workers, and which we eventually called patient navigators. And there wasn't a whole lot there for us to go on. Now, personally, I had been very involved in a state publication that was through our Department of Health and through James Madison University. Massachusetts had already published a report in 2009, I think. We published ours in 2006. There's a couple of others that I've listed here for you. And the 2 that are in yellow were the only ones that we had available for us in our early development. Now, I have to admit, and this is where we have some people from Minnesota on our call, and you could probably tell me about this. My best understanding in working with the contact that I had at that time was that Minnesota integrated community health worker training in their community college system. But to actually get their training, they were not very willing to give me a whole lot. I got an outline for them, and that was about it. So this is what we had to go on. And so over the years, as these other state reports came out, we would actually access them and we used them. So what we did early has evolved over this decade. In 2016, I mentioned this yesterday, the C3, or the Consensus Project, came out through the University of Texas, through some private funding. And they listed communication skills, the different skills that a community health worker needed to have, their capacity skills, their advocacy skills, education, outreach, professional skills, looking at the ethics, their professionalism, research skills, and their knowledge base. We had already done our initial training, so we'd already kind of figured this out. But it was nice to see somebody else produce this and publish it, and we go, oh, okay, we're on track. So what we did a couple years ago with all of this history, we went back to the literature and did a very formal review of the literature and pulled over 200 and some articles and looked at the functions, what are these community health workers supposed to be doing? Because we were kind of looking at ours and say, are we teaching and are we training on the right things, okay? And this chart came out of that fairly extensive literature review. So the chart I've put in, I don't expect you to be seeing it all, but I put it there so you could see it, that shows, and we kind of arbitrarily place these under the domains. And in several other states and within the C3 project, they clumped functions together in anywhere from 6 to 9 domains. So we, in working together, chose the ones that we felt were relevant and useful. So that's what this is. It's just a chart of what this team did in looking at our experience and looking at what the literature was saying. We actually got this published, and it's in, and we've listed that reference, and you are welcome to go to that. And there are a couple of supplements in that's included that actually list every single article that was listed and actually listed those functions and gave frequency tables. In other words, if they said one of the functions of a role of a CHW is to help patients make appointments. And they may have said that many different ways, but we arbitrarily put it under make appointments. And in our article, we actually put the number there. So if that was said by 5 articles versus 40 articles. And therefore, we were able to see what were the most prevalent functions that were happening in our country. And this was based on the United States. We did not look at other countries. So we found that there was a lot of overlap and distinctions among community health workers and other healthcare workers. And that's why we're showing you there, and we've talked about this now a couple times over these last 2 days. As you look at your teams, that's why you have your team. There's not any one professional that can do it all. And, there's a time we used to think, well, the doctors do it all. And if you watch TV and watch the doctor show, they do it all. They move patients from the room to the ER or to the OR, and they give all the medications, and they mess with the IV pumps, and, they just do all of this. Well, I hate to tell you, but, I haven't practiced in a while, but I really don't think doctors are doing a lot of that. I really think, in fact, nurses aren't even doing a lot of that. We have transportation technicians, and we have all these other people. There's a very rather large myriad of people in hospitals in acute care setting taking care of patients. If you get out in the community, it's rather variable out there too. So we drew this as that the patient is at the core. So you may have a nurse, you may have a nurse's aide, and in some places we have nurses' aide out in the community doing all kinds of things. I haven't heard that in regards to our sickle cell teams, but in the community we've been using. We have public health nurses. That's my background. I was a public health nurse going out to the homes and seeing patients in their community. And public health nurses pride themselves as being out there since the 1890s and lying in hospital and doing all of that and really looking at holistic care. Social workers have had some of that same, looking at the holistic care and looking at patients in communities. So there is overlap there. Health educators, I've worked with a bunch of health educators in my career, and they have a whole different training. They're not nurses, they're not social workers, they're health educators, and many of them have bachelor's degrees. And so when you're working in public health, you might work on a team with nurses, social workers, health educators, and then even in my world, I'd have policy analysts, and they came from a whole nother world. But in working with clients, we found that that was a good thing, an excellent thing. So depending on your geographic area, you may see different people out in the community doing similar things, but yet there may be some different things. So there is a lot of overlap. So therefore, what in the world, what is different about a community health worker? That, I think, community health needs health workers, that workforce, they have got to get a really good handle on that. And I went over this slide, I put it in today just to remind us that they are really not doing the clinical care. They should be focused on the community. They should have either a wonderful understanding, in-depth knowledge of the community, and in some programs, they actually come from the community. So it kind of depends on how you design your program. They should be able to share some of the culture of the patient population you're working with. And they should not be addressing medical issues. I'm going to qualify that in a minute. And they really should be able to mobilize the community to target certain issues. And so that's a whole nother role that I see our community-based organizations really shine, in that you may not be involved in that patient, say Keith, in working with Keith's story, but you may be advocating and doing things in the community, providing some general kinds of education about sickle cell or sickle cell awareness, or doing projects that educate the community. So there's a very vast list of what folks can be doing. So a summary, what we learned from the literature and we learned from people like you and from looking at what was going on in our country, it kind of all comes down to these, 7, I think. Health navigation and care coordination. And we purposely used care coordination. And that in some groups, you need to be careful. If you say the word case management, there are professionals like Shirley and those of you that are social workers, that has very significant meaning to you as a case manager. If you're in the government and you're working with Medicaid, that has very significant definition. Case management is very specific. What our health navigators, our patient navigators, our community health workers are doing is more that care coordination. So we need to be somewhat sensitive to that. It doesn't mean you're not going to hear the word case management. You're going to hear it all over. But if you're working in an area like in government, like I had to be very careful because I was working with social workers and Medicaid and all these folks, and I couldn't just use case management interchangeably. I had to be careful. Coaching and social support, very significant. Culturally competent health education, and that you see a lot of that. Direct service. Now this is where it gets interesting. We said they shouldn't be doing clinical care. So no, they ought not be in the clinic taking blood pressures and temperatures and weights and doing patient check-in, all right? Well, guess what? Life can change and depends on your system and where you are. The pandemic completely changed this. We had community health workers doing the nasal swabs during the pandemic, and we're out as being a very important part of the actual testing. All right, so we had to, of course, train them on that. So across the country, community health workers actually stepped up and took on some direct service kinds of activities. Even though in looking at the literature across the nation in our lit review, direct service was fairly rare, okay? But in some areas, I know right here in Virginia, we have some programs out in our far southwest where community health workers take blood pressures and do weights because we don't have enough providers, and they're going into the home and they do it. So they've been properly trained to do it. We have, in California, they have community health workers that do blood sugars, the pricks, the sticks. So, it depends on your area. Outreach and case finding, depending on where you are, we actually explored this function within our program and having our community health workers go out into the community, going to functions at community groups like in churches or community centers in an attempt to do case finding. So that could be a very major role. In our literature review, it was not as prevalent as we thought we were going to see. Participation, evaluation, and research is also one that you see reported in the literature. We certainly used our community health workers or patient navigators to participate in the research project in that they collected data, they completed forms, they were trained on our REDCAP, and that was what was used, our electronic form of collecting all of our patient data, and they were a very important part of that. And we also used them as we went through our project to evaluate things, to give input. I remember one thing we did way back when is that when we did our training, went back and interviewed all of our community health workers that participated in the training and asked questions like, well, did you use that information? Was that good? Was that not so good? What do you need? Blah, blah, blah. So they were very much a part of the process, but this is not a highly prevalent function that you see across the country. So as I mentioned before, the impact of COVID really did change some of this. We have community health workers training on protective equipment, the PPE. They had to learn how to do it. They actually were a part of teaching the population. They really had to shift, and I know this is something Shirley can really address because they had to live this. I didn't, they did. Of shifting from their in-person, making home visits to complete virtual contact. I think some of that has shifted back a little bit. I think Rachel Walls referred to that a little bit. So that was a major shift, and it's still occurring. And I think the virtual contact probably is not going to go away as we see that shift. Addition of other fun, I mentioned contact tracing. We had community health workers in our country that got very involved in food service, food distribution projects. There's one in not far from where I live, major warehouse, and one of our community health worker groups went down and helped with food distribution. So training on COVID and prevention strategies became absolutely critical to the functions and roles and responsibilities of community health. And I've mentioned the C3 project. I won't belabor that. I guess because it became almost like our Bible, in that there was this document that was that came from across the country and that pretty much said, this is what community health workers should be doing and this is how they ought to be. These are the capabilities they ought to have. But that particular publication did not address a core curriculum. They listed some things that ought to be in a curriculum. And we look at that and we go, oh, well, yeah, we kind of figured that out all by ourselves back in 2012, okay? But it was nice to see a document that came out. So in that, I've listed here some of the core curriculum content. Some of you that are maybe working on your program and you might want to expand and bring a community health worker model into your program, this would be helpful, and we will be very, in fact, I'd be very willing, and I think, to help provide some consultation on that, because we've been down that road. And that's kind of how this SCCAPE conference came about. As we evolved and we trained people over the years, we knew that there was some real interest in this. So we had our first SCCAPE conference in, 3 years ago now, before the COVID hit, and this is part of what we were training on, is to, if you're going to do a program, these are the things you've got to make sure you include in a curriculum if you're going to do training of community health workers. So that has been out there. And then as we've evolved and learned, and as I said, we interviewed the folks that had been trained, we said, well, what you got. And they were all very positive about what we had done, but they made it very clear. We need more on motivational interviewing. Oh, okay. We need more on setting boundaries. We need more on the safety issues, how to make a safe home visit, how to do this. Oh, okay. Community engagement. It's like, yeah, we need more on that. Planning for the unexpected. And I know that Shirley could give you a whole afternoon on that. So, clinic exposure. One thing that we had not built into our initial training, but we did very quickly, and we kind of knew that to start with, is that having the community health worker have a chance to go see sickle cell treatment and care up front and personal, and that they really needed to understand and see what was going on. Even though we gave them a fairly rigorous review of sickle cell disease, they wanted more, and they wanted to actually see it in action. So we built that in through the hard work of Shirley and some of the other team members, and actually had them spend time in the clinics with the doctors interacting. Now, when we were doing our project, we had to be careful because we had a controlled study, and so our providers were not supposed to know who had a community health worker or not. So we had to be careful on that. But then once the study was over, and then even then we still built some of that in. We just had to be careful. And they go, "Hi, I'm Mrs. Jones, community health worker, and I'm going to observe in clinic today." No, couldn't do that. But so setting the boundaries for healthy relationships was really important part. We certainly did some of that, but in doing evaluation, we knew that we had to increase that. Other key topics that have now come about is person-centered care, which I loved it in some of our response this morning. You guys were on point in that many of you spoke from a person-centered care framework. I love it. The medical home, we realized we really needed to talk more about that. Conflict resolution, which we do have it, don't we? So probably adding some of that to a curriculum is a good thing. And then we really realized, especially when COVID hit, is that all of us are having COVID fatigue. So can you imagine if you're out there dealing with people who are suffering from all kinds of complications of a chronic illness? So the whole idea of burnout and compassion fatigue and COVID fatigue. That's why I think this afternoon we have a guest speaker to actually provide us with some further insight on that. Because if you're going to build a program, you're going to have to build in some of this kind of dealing with your staff to build resilience. Other key I did that. I need to move on. So a summary about this whole curriculum and all of what you're going to do, it's a big patchwork. All right, there's a wide range of variability across the country. There's much overlap of roles, and there's agreement that patient education, healthcare navigation, and social support is most important. And this statement is important. I probably should have put it in another color. This is not just me saying this, okay? This is from the literature, from the national other people out there doing this. Of all of those functions, these are the 3 top ones that people are doing and doing consistently. And that's done through our remember I said I did a little frequency analysis of all of this. So they are the top ones. And here's our categories again. And this is not the be-all, end-all, but it's what we've learned from this experience. And when I say we, I'm including a multidisciplinary team. And I have to admit, there were a couple of interesting conversations as we looked at general versus clinical versus health navigator. I kind of talked a little bit about the peer. I talked a little bit about the health navigator. The 2 in the middle is where there's lots of overlap and not really anything very cleanly delineated. I think Shirley's going to get into a little bit more detail about how that overlaps. So I'm not going to take her thunder away. But I'll go through just a few general comments. Usually peer programs are lay workers. They aim to affect self-care. They provide education and social support. Okay, that's pretty much, and you still got to train them though. You can't just let them go out willy-nilly. The general it's aimed to affect patient behavior and patient-clinician relationships. It's community-based, and you work as that community liaison. And these folks may be based in a lot of different places. So they may be at the Federally Qualified Health Center, they may be at a rec center, okay? They may be just about anywhere. We've got some in our area in a satellite clinic in a project in the neighborhood. So they can be in a lot of different places. The other category of that other part, we think, are the clinical community health workers. And these were a lot of the folks that I'm hearing that you guys are dealing with or you're thinking about having will be true members of the medical care team. They'll be hired by the institution, supervised by the institution. Their major function will be the navigation and the education, and probably more individual advocacy, not so much community advocacy, even though that cannot be ruled out. Where the category 4 is what I mentioned earlier, the health navigator. They usually have a minimum education, an associate degree. They're hired by an agency and institution. They serve as a medical care team, and their major function is that navigation. I heard someone speak of having a nurse navigator, and that model is certainly out there, where there's nurses who is a registered nurse, but works in that care coordination, patient navigation system. And that model is certainly there. In fact, it's very prevalent and works very well in the breast and cervical cancer world. And that's kind of how it was modeled, and that's where some of my experience was in working with the CDC Breast and Cervical Cancer Project, which is still going on. So now let's talk a little bit, and I better check my time. I don't know where I am. Is challenges for this somewhat new workforce, the community health workforce. Is ensuring quality workforce. Oh, this is a big one. We could have a whole session on that. As professionals, those of us that are nurses and doctors and social workers, we can get pretty like, ooh, who is this person and what are they going to do? And they're going to go in the home and make some kind of stupid remarks, and are they going to do this and that? We have that concern. And hospitals and institutions are going to have that concern. Medicaid has that concern. They don't want just anybody out there interacting with patients because of the liability question, for one thing. So ensuring quality workforce, sustaining or funding that workforce, and integrating that workforce into existing care teams. So let's talk about these a little bit more. I gave some of this statistics the other day, whenever it was, ensuring quality. So what can we do about that? You at your institution, you can do some stuff about this. You really can. We have several states. Then here I have 5 states that have formal advisory boards. These are formal where you may have to know the governor to get appointed to it, okay? But there's many other states that have advisory boards that let just about anybody who's interested come on board. I live in one. We have an advisory committee. I've been there since almost day one. We're now getting more formal, where you're going to have to fill out a form and do all this. You're going to have to represent somebody. But right now, it's like whoever was interested in community health workers could be a part of the advisory group. Legislation, we have 12 states that actually have it written in code, where they define what a community health worker is, and there's codes around that. And of course, when you have a code, you're going to have regulations. Those of us that are licensed people, we have lots of regulations we have to live by. Well, at this point, there's no licensure of community health workers in the United States, all right? There's some that are talking about it, but it hadn't happened yet. The certification, that's happening in 12 states for sure. There's other states that are talking about it. Certification, though, is different from licensure, and I think you probably all realize that, but some of you may not, in that Dr. Smith, he probably did a certification in something. I did a certification as a nurse practitioner above and beyond what my registered nurse gives me the privilege to practice. If you're in another area, you may take a certification exam and say infertility, and you become certified in that. Where licensure has to do with the state actually requiring you to have that in order to practice your field in that area. And those of us that are licensed, usually it's all related to our state, and there might be a reciprocal process. If I want to go to Mississippi and practice, I got to make sure I'm either granted that privilege through Virginia or my license, or Mississippi recognizes, but all of that is very formal, lots of licensure. We don't have any of that. We do not have licensure for states. We do not have any reciprocal relationships between the certifications at this point. Now, Virginia is talking with Maryland. I think at some point we're going to have a reciprocal relationship, but it doesn't exist yet. Texas has got very extensive certification. They have levels of community health workers, and you can go take a special exam and become a community health worker that specializes in women's health, okay? Not all states have that. So there's a lot that could happen, and if you're really involved in it, you probably should stay abreast of those things in your state, and if you can, get involved as best you can. That's how you're going to know. Now, sustainability is the funding issue. How have we funded community health workers up till now? Mostly through grants. Ours were started with grants. We eventually have now institutionalized 3 of our community health workers, like Shirley expressed the other day. That's, of course, the perfect. We talked a little bit about Medicaid reimbursement yesterday. Some places, how they're doing it, and this is true across the nation, is that a hospital may say, ooh, like the Coleman model, remember? You know what? We can save us a lot of money and time and effort if we have these people that come into the hospital and meet with these patients after they've had their cardiac event and make sure they have a primary care or a primary cardiologist and that they get their medicines and they know how to get their medicines and they know how to take their medicines and they do this and they do that. And we can keep them out of the hospital for 30 days. Well, guess what? They pay those people through their administrative dollars within their institution. And that's how some of these folks and programs are getting funded. It's not a bad model. There's probably some pros and cons. But so far, that's what's happening across the country. I put this in just to show you that on the medical care team, we've been talking about it. We're going to talk about it some more. But the patient navigator is truly a member of that medical care team. And at this point, I think our best. Now, I mentioned that I put this slide in again because it's so critical. Most of community health worker practice is not within a medical team. So for some of us, that is where we get we have some concerns. It's like, well, who's supervising this person? And what happens if that, they get into a situation and they don't quite know how to handle it? Who do they go to? And see, in our model, in our program, that's very clearly delineated. There's people on call and there's all kinds of good people and good resources that we can work with. Some of the other resources for you folks and for us is there's a lot of good resources out of CDC. We now have the toolkit, which I've alluded to in your virtual handbook. So there's a lot more out there than what we had in 2011 when we were trying to design our program. Now, the curriculum, that's still up in the air. I know, like, for the sickle cell world, the association has had a program and they have a curriculum. I think that there's some real interest in developing a standard curriculum in sickle cell. I know Dr. Smith's been approached about that. So we're just going to see. We're in a very exciting time, and we hope that over the next few years, we're going to see some really good resources to say, okay, if you're going to become a community health worker in sickle cell, you're gonna need this training here and this training here and that training there, and those experiential or clinical times, internships, whatever you want to call them, because we are learning that you cannot sit in a classroom and get didactic and expect to come out next week and be an effective community health worker. That you need some of that upfront didactic, but you need ongoing supervision, mentoring, time to spend with patients, with supervision maybe, with patients in the clinic. So there needs to be experiential time. That's why the community college system has some real benefit, because they usually build in, just like if some of you have taken a course, say, in chemistry, and you have 3 hours of chemistry lecture a week, but you have 5 hours of chemistry lab, and you go show up at a different time in a different place, and you learn your chemistry in a lab. All right? That's what we're talking about. And that good community health worker education needs to have that in person or through virtual didactic, but you also need that experiential time with good peers and supervisors. So a good program needs both of those. You don't just train somebody 4 hours this week and expect them to go be effective next week. It ain't gonna happen. I can tell you that from what we know. All right, I've listed a bunch of these resources. I have not listed all of them. If you want a complete list, you can always give a shout to me, and I will give you all the resources that I know of. There are articles coming out every few weeks, so I try to stay on top of it. But at this point, no. Now, the other piece I wanted to mention today that has become even more important. And see, this is what happens. You put all this together, and then you read an article. And then I get, oh, yeah, this is exciting. When we put our program together, we were kind of flying by the seat of our pants, to be real honest. Because there was experience in Virginia with like peer programs and some of these other programs, we certainly knew things, and we certainly went to the literature, and we had our 2 state publications. But to really truly sit and look at a theoretical framework, we knew we had to use adult learning theory. That was pretty obvious. We knew we were into behavioral health theories, okay? So we had that knowledge in our grasp, because after all, we had a good team of experts who certainly been teaching and working in the field. We knew we had these sickle cell experts. That wasn't a problem. But as we look back, we realized that yes, indeedy, we used some very specific theoretical models, but we really didn't identify them as such. So I want to just list the ones that we used. The ecological perspective, or the ecological model, we certainly used, because you can't be a public health official and not use it, and that's kind of where I come in, where you look at the individual level, and then you move up the chain into where you get at the community level, and you look at institutional level. So we certainly looked at that. We used the what's called the social cognitive theory, which in the olden days was called the social learning theory, but now has got an updated title. We were very much into the self-efficacy construct, even though we never named that anywhere in our writings, but we were, because even thus the title of our conference, we used the word empowerment. We know that we can't make that person over there do what we want them to do, but what we got to do is figure out how do we partner and link to them to be able to say, you know what, I need to take my medicine, don't I? Well, how can we get you to do that? What is it that you can do? So it's that self-efficacy model that I think the team really embraces. Okay? The trans-theoretical model, which I'm going to talk about a little bit later today, is certainly one of the underlying theories that we used. And then certainly social support and social networking was another theoretical model that was an underlying principle. And then the one that is, again, kind of out there is the community-based participatory research, which some of you may have very well been a part of. This was really a key word back, 10 years ago. But it's still out there. It's that whole piece of linking to the community and doing things with the community. And in other words, instead of the big institution sitting there and saying, okay, we got this theory, this hypothesis, and we're going to do X, Y, Z, and we're going to have these wonderful outcomes. And if you're trying to affect community, then you got to go ask the community what it is they think it's important and how are they. And so for us in the sickle cell world, that frequently is our community-based organizations. So that is becoming much more critical, and we realize that we really got to work within the sickle cell population in our community to figure out where we are. So therefore, do I have any questions or comments before we move on? I don't see any.